my name is Emese Kasznár. In the next few minutes, I will present you my PhD topic, physical activity in inflammatory bowel disease. I'm a medical doctor at National Pediatric Institute, and my vision is to improve the management and quality of life of IBD patients. And for this, my mission is to encourage IBD patients to exercise to reduce disease burden. I have 3 ongoing projects right now. The first 2 will be systematic review and meta-analysis, and the third one will be a protocol of an international randomized clinical trial. So a little bit more about the first project. It will compare the physical activity between inflammatory bowel disease patients and healthy control. IBD's prevalence in 2019 was 4.9 million worldwide, including adult and pediatric population as well. IBD is a relapsing-remitting disease of the gastrointestinal tract, which can affect daily activities and quality of life. During a moderate to severe disease activity or after surgery, we know that patients are less active physically, but some data suggest that during remission or mild inflammation, they tend to be inactive physically. We know that reduced physical activity can lead to sarcopenia, decreased bone mineral density, metabolic syndrome, and other chronic diseases. So our aim is to compare the physical activity of healthy population and IBD patients. For this, our clinical question: do patients with inflammatory bowel disease exhibit lower levels of physical activity compared to healthy control? So the exposure will be the inflammatory bowel disease itself, and the comparator will be a healthy control. The primary outcomes will be metabolic equivalent of task minutes, moderate, time spent in moderate to vigorous physical activity, functional capacity, and fitness. And we will also have 5 more secondary outcomes. Our hypothesis is that healthy people are more active physically than IBD patients. And the clinical implication would be to encourage IBD patients to be active physically to reduce the risk of osteoporosis, sarcopenia, and metabolic syndrome. We did our systematic search on November 16th in 3 databases with the following search key. It contained 2 domains, the disease itself and physical activity. As you can see, we had more than 13,000 hits. In this key article, they compared the physical activity between Crohn's disease and ulcerative colitis patients to healthy control, and they measured 4 out of the 9 outcomes. But it was a cohort study and had a small sample size. So after the duplicate removal, we had around 10,000 articles, and after the title abstract selection, we had 700 articles. Now we are at the full text selection phase, and I'm at about 20% finished. The second project will investigate the disease activity and quality of life before and after physical intervention in inflammatory bowel disease. As I mentioned before, patients with inflammatory bowel disease tend to have reduced physical activity. They can have decreased bone mineral density and muscle mass, and they also can have anxiety and depression. In 2022, there was a meta-analysis in adult IBD patients, which conducted that physical activity is beneficial to the disease. It can improve the bone mineral density and the quality of life of the patients. But we know that 25% of IBD patients are diagnosed in childhood. So in our analysis, we would like to include them as well. So our aim is to analyze the effects of physical exercise on disease activity and quality of life. For this, our clinical question: does exercise intervention affect disease activity and quality of life in IBD patients? The intervention can be any kind of structured physical exercise, and we will compare the outcomes to the baseline measurements. The primary outcomes, as I said before, will be disease activity and quality of life. Our hypothesis that physical activity beneficially influences the quality of life in IBD patients. So our clinical implication is to encourage IBD patients to exercise more to improve their quality of life. We used the same search key as I showed before, so we had more than 13,000 hits. In this key article, the patient had a 6-month-long exercise intervention, and they measured the body composition with DEXA. They included Crohn's disease patients, ulcerative colitis patients, and IBD patients as well. They measured 4 out of the 7 outcomes, but it had a really small sample size, and it was a single-center pre-post interventional study. So as I mentioned before, after the duplicate removal, we had around 10,000 articles, and after the title abstract selection, about 700 articles. I'm at the same progress with the full text selection. And the third project will investigate the effect of structured physical exercise in children with Crohn's disease. This will be a protocol of an international randomized clinical trial. So 1/3 of adult IBD patients have sarcopenia, which means decreased muscle mass and function. We know that sarcopenia can have a negative effect on medical therapy. It can lengthen the postoperative stay and decrease the bone mineral density. In children with Crohn's disease, the first-line therapy is exclusive enteral nutrition, which is a specialized liquid formula they take to 6 to 8 weeks. We do not know the effect of exclusive enteral nutrition on the muscle mass and function, and we also do not know if structured physical exercise can prevent or treat sarcopenia. So our aim is to observe the effects of structured physical exercise on sarcopenia in Crohn's disease. For this, our clinical question: does physical exercise mitigate or prevent sarcopenia in Crohn's disease patients? Our population will be children with Crohn's disease. The intervention group will have exclusive enteral nutrition plus structured physical exercise. The comparator will have only exclusive enteral nutrition, and we will measure sarcopenia at diagnosis and 8 weeks later. Our hypothesis that structured physical exercise mitigate or prevent sarcopenia in Crohn's disease patients. So the physical or the clinical implication that physical activity should be included in the guidelines to mitigate and prevent sarcopenia. So in summary, I have 3 projects that are investigating the effect of physical activity. Hopefully the first 2 I can finish in September next year, and the third one in 2025. I would like to close with Carl Sagan's words: somewhere something incredible is waiting to be known. Thank you for your attention.
You investigate this exercise in remission, yes?
Yes.
During remission, yes. And not during after relapse. You know that in the adult patients, they don't use the exclusive enteral nutrition. This is in the pediatric population. What do you think? Would you interesting to choose an adult population who got the regular treatment, as was in the children several decades ago, or maybe 2 decades ago, and to compare whether in children with exclusive enteral nutrition plus physical activity brings a better results than, for instance, in young adult in whom the disease starts in that time, and only the physical exercise. So because they don't use, the internists don't use the exclusive enteral nutrition.
Thank you for your question. I think it would be interesting to compare the 2 data if it would be possible to have those data that measured these adult patients. We could certainly compare the 2. Thank you.
Thank you for your presentation. I was really intrigued, especially by that part when you talk about anxiety and depression. And judging by those articles that you've skimmed through so far, what do you think is the effect of physical exercise on these 2 constructs? Or if there was no mention about the relationship, what do you think? How could, for example, physical exercise plus psychotherapy together help these patients?
Thank you for your question. In the articles which I checked so far, there are some which use yoga as structured physical exercise, and they are measuring anxiety and depression in these articles. And sadly, they have a low patient number, around 10 people or around that, so it cannot have a statistically significant outcome, but it was decreased in these patients, the anxiety and depression. And there are another kind of intervention, the mindfulness, which they use, but that's not my topic, sadly. But in those parts, it is also improves the anxiety and depression. Thank you.
Thank you for your talk, very nice. I have two questions. One is about your first topic, about their physical capacity. Disease course can vary from patient to patient. Some of them may be in remission for a longer time, and some of them can have several relapses. How do you plan to tackle this aspect in your analysis? So this would be my first question, because I presume or I assume they could have different capacities in these two situations. And my second question is about the third topic, very nice. How did you come up with the 8-week time period for the measurement of your outcome after the intervention? Thank you.
Thank you for your questions. So the answer for the first one, in the articles which I checked already, they only included those who are in remission, so excluded those who have high disease activity scores. And for the second question, the exclusive enteral nutrition is lasts for 6 to 8 weeks, so that's why we want to measure them after 8 weeks. Thank you.
Congratulations for your presentation. I have a question related to the first topic. What are the key guidelines related to the exercise? You mentioned yoga, but how often, or what are the key?
Sadly, there are no guidelines. That's why we are investigating this. There's only the ESPAN guideline, which is a nutritional guideline, and they recommend resistance training in those who have sarcopenia, but it does not have an evidence-based structure for it, because they have not conducted enough research in IBD.